I think we'll get started on time. I'm sure there'll be a few more people coming in. Sorry for the change in venue. It's always a trick to find a room at a given time, but we're just thrilled to have everybody here. And thanks for coming out on this gorgeous day. I mean, I wouldn't blame you for going home early and enjoying this beautiful fall weather, but we're just so pleased that you're here with us today. I always like to preface the Dean's lecture by conveying the significance of earning the rank of professor at the Bloomberg School, earning the rank of professor anywhere, but let alone the Bloomberg School of Public Health. Attaining this appointment represents an incredible achievement by a senior faculty member and confirms not only the respect and high regard of the school, but of colleagues across the nation and indeed across the world. The Dean's Lecture was established many, many years ago to provide an opportunity to highlight the extraordinary work of our newly appointed and promoted professors. And today's event will not disappoint. It is an honor to introduce Dr. Amy Knowlton as today's Dean's Lecturer. As many of you know, Amy is a leading scholar investigating not only the health of disadvantaged populations and how they utilize health services, but also, and I think very importantly, the associated impacts on their caregivers. Her research broadly focuses on microsocial processes of marginalized populations' health disparities and resilience, optimal health care engagement, treatment adherence, and well-being through the end of life. She is a longtime investigator of community-based research with colleagues at the Department of Health, Behavior, and Society's Lighthouse at Pierpoint. And with Lighthouse colleagues, she has examined the understudied role of formal and informal caregiving relationships and support networks on HIV, healthcare, and treatment adherence and outcomes in African Americans. She has been the PI or co-investigator on numerous caregiving dyad-focused longitudinal studies, including the recent AFIRM care study that examines the role of chronic pain on HIV, health caregiving relationships, and end-of-life healthcare decision-making. She is currently a co-investigator on a cluster randomized clinical trial testing long-term outcomes of a healthcare facility focused intervention. And this intervention promotes patient-centered clinical practices to address access and adherence to HIV treatment and, very importantly, to prevent mother-to-child HIV transmission in Lesotho, Africa. Previously, she partnered with the Baltimore City Health Fire Department's emergency medical services to examine and intervene on patients with behavioral health problems. Based on the findings of her studies, she galvanized stakeholder support for developing the city's Sobering and Stabilization Center. This center addresses unmet needs for comprehensive crisis services among vulnerable substance-using persons who may otherwise be transported to hospitals or to jail. Her work has resulted in over 100 publications, peer-reviewed publications, as well as numerous book chapters, and she has served as an editorial reviewer on 14 journals, including AIDS and Behavior, as well as the Journal of Urban Health. Dr. Knowlton received her BA in biochemistry from Beloit College. But before pursuing her graduate education, she was a research lab technician in the Department of Internal Medicine at Baylor College of Medicine, a health sciences teacher with a Peace Corps at St. Philip's Secondary School in Swaziland, and an ASPH, I guess now ASPPH, intern at the Centers for Disease Control. But most proudly for us, she is an alum of the Bloomberg School, receiving her MPH in 1992 and her SCD in International Health in 1997. She was appointed to the faculty in 2000 as an assistant scientist in what was then the Department of Social and Behavioral Science, the Division of Social and Behavioral Sciences in the Department of Health Policy and Management. And her appointment was moved to Health Behavior, the Department of Health Behavior and Society, when that became a department in 2005. She was promoted to associate professor in 2007 and to the rank of full professor in 2018. I am delighted that Dr. Knowlton is here to present today's Dean's Lecture, and I'm sure it's going to be an eye-opening presentation. Please join me in welcoming Professor Knowlton.
Good afternoon. Thank you all for coming at this late time of the day and a beautiful, gorgeous sunny day. I'm going to be presenting findings from my research program with African Americans living with HIV here in Baltimore. Through this work, my collaborators and I have developed and tested a framework of social processes involved in the population's health disparities and well-being. The intention of this work is to make visible the interdependence of community members, their health, and their collective resilience. I'll first start with an overview to underscore the main messages of my talk and my research program. Now, in the US, most people living with HIV have behavioral health problems, drug use disorders, mental illness, and 40% are African Americans. Challenges engaging in the healthcare system with healthcare providers and adhering to health regimens play a major role in their health disparities. My research is focused on the role of support networks and main caregiving relationships with family and friends in these behaviors and health. I'm conceptualizing caregiving as a health promoting process, as a female gender role, traditionally a female gender role, and as a stress process. The findings have implications for understanding and intervening on African American community health disparities and resilience. But first, some background on how I got started on this. I grew up in the South and in Chicago during the Civil Rights era in the late 60s, early 70s. And my family joined an intentional community that had a mission of community uplift and transformation. And we lived in poor communities, and I attended Black segregated schools. From early on, I had a loose sense of family and an appreciation of the power of caring relationships and resilience. In the process of adults trying to transform the world out there, there was a lot of neglect and mistreatment of children. And so I had a very early understanding of just how important that is. I came to Hopkins in 1991 from Swaziland. There I was a Peace Corps volunteer at the very beginning of the HIV epidemic. Swaziland, now called Eswatini, not to confuse, the king was concerned about confusion with Switzerland. True story. Swaziland has the world's highest rates of HIV. I lived there during the apartheid era. And I was struck by both the deprivation of the community I lived in and their basic humanity, the kindness and care they demonstrated toward others, even in the most inhumane of contexts. I observed similar social challenges to community health there that I later saw in Baltimore. And I came to Hopkins knowing that I wanted to work in the area of caregiving as community resilience and adaptation to HIV. In the US, Baltimore has among the highest rates of HIV, and African Americans comprise the vast majority. Their rate of viral control is well below the US average. While currently HIV transmission is primarily through sexual behavior, substance use continues to play a major role in African Americans' disparities in health outcomes of HIV. Now, HIV affects accelerated physiologic processes of aging, and social stress is a major contributor to aging. African Americans, and especially African American women, have worse health outcomes of HIV compared to other race and sex groups. And this is largely attributed to their high-risk lifestyles and poor engagement in healthcare and treatment. Social support is often defined as the global perception of feeling loved and cared for. And this emphasizes emotional support and support as a static personality trait. And it also ignores behavioral dimensions, which may be especially important to populations with a high need for support and actively trying to utilize their support services. So here I define social support as interpersonal exchange of basic resources important to health. And there have been consensus among investigators of these basic types. So they not only include emotional support, but also instrumental support in terms of people who give up their time and energy to help you out with day-to-day tasks like chores, material and financial support, informational support like health advice, and socializing like people you hang out with to enjoy spending time with. So this definition emphasizes social context and agency in adapting to life challenges. Main relationships play a vital role in health and well-being throughout the lifespan. They may affect adult health through shared lifestyles and norms and through influences on health behaviors. However, they are largely unacknowledged by Western medical perspectives and by healthcare systems, healthcare delivery systems, clinicians, and policymakers. My work has focused on social factors as an integral facet of mind, body, and health. My work posits social processes as of a biopsychosocial model of health. And if you have any questions, feel free to ask. I focus on social networks as the interpersonal level of the social ecology or social determinants of health. Through this work, I've applied and expanded on earlier research on support networks. My work has delineated dimensions of network function, network structure, and qualities of relationships linked to health and well-being. And while most of the social support and caregiving literature emphasizes positive aspects of relationships, I also look at negative aspects as well. This is a schematic of the framework that I've been developing and testing in my work. And as Deborah Roeder's pioneering work has established, patient-centered patient-provider relationships are very important to health. And that is something that I've looked at as well. My work is focused, though, on delineating informal or unpaid caregiving and other support resources. Informal caregiving is often defined as unpaid instrumental or emotional support by family or friends to someone with a serious condition, life-limiting or limiting of function. It's their main source of care and is increasingly important with population aging. It's also a hallmark of the human species. Long-term caregiving is something that distinguishes us from other species and is considered irreplaceable by technology. One of the few things aside from innovation. Although there's probably an app out there for it, so don't quote me. And low-income African-American women provide higher levels and more intensive forms of caregiving than do other income and sex groups in the U.S., and that includes for HIV. And African-American women report lower levels of caregiving-related burden or distress. So the literature has minimized the health effects of caregiving on African-Americans. Discord in main relationships has stronger effects on health than do positive aspects of support. And caregiving can be highly stressful to both caregivers and care recipients, in that it may strain potentially limited resources and proliferate stress. Stress to care recipients, caregiving care receipt can be stressful if people feel indebted or burdened, or it makes them feel inadequate, etc. And in fact, being a main caregiver is predictive of later depression, reduced social support, and morbidity and mortality. And reduced support, by the way, is a predictor of cessation of caregiving and institutionalizing care recipients. Yet little research has been done to conceptualize, let alone examine, these pathways. So this is novel work, and in a very understudied population of patients and caregivers. HIV caregiving adds to African Americans' intersectional stress. And by this, I'm referring to the constellation of stress and stigma experienced as part of, because of their race, HIV, drug use, poverty, etc. And HIV caregiving in this context may compound such stigma and stress. Among women living with HIV, higher levels of African Americans than women of other race endorse traditional female gender roles, such as tending to place the care needs of loved ones over their own needs for self-care. And for many people who are caregiving, if they're living with HIV and caring for someone with HIV, they may be dealing with challenges of their own limited resources, their own behavioral health problems, as well as, of course, the behavioral, let alone somatic health conditions of the person they're caring for. So the research questions that were driving a lot of this work were, first of all, is this population of current or former substance-using people, African Americans living with HIV, able to mobilize community support? A lot of people have been doubtful, clinicians often especially. Secondly, how does receipt of support resources affect the health of people living with HIV, both directly and indirectly through effects on health-related behaviors? Thirdly, how do stigmatizing comorbidities affect the social support of this population? And then finally, how does HIV caregiving affect caregivers' own health and well-being? Have I been off? Sorry. It's confusing. There's two different, sorry about that. Personal networks have been considered core relationships through which people access and exchange resources important to their health. In our research, we elicit names of support network members by asking participants who they could or who they recently did rely on for each of the basic types of support. Now, network methodology emphasizes active relationships and relationships of choice. Over a 20-year period, we've conducted a series of studies with this population, including 4 dyad-focused studies of caregiver recipients. Initially, we recruited participants in the ongoing ALIVE cohort study, and more recently, we've enrolled patients from the Johns Hopkins HIV clinic and their main supporters. Each of the studies emphasized the role of support resources in various key behaviors or outcomes of interest. We identify main caregivers using specific name-generating questions. We ask for the first names or street names and the first initial of the last name of persons whom the participant relies on for emotional support, meaning who could you talk to about something personal and private, or instrumental assistance, including help engaging in healthcare treatment. For example, who could you rely on to go to the pharmacy to pick up a refill? Or who could help you with transportation to get to doctor's appointments? In the case of a tie, priority was given to selecting and recruiting main partners as relationships of choice and female kin. Measures included outcomes of healthcare access and utilization, access and adherence to antiretroviral therapies, or ART, and healthcare decision-making for end-of-life healthcare preferences. Viral control was defined as an undetectable plasma viral load, and independent variables included current drug use, meaning in the past year, chronic pain interference in function, patient-centered patient-provider engagement, which can be defined as care practices respecting patients' values, such as shared decision-making, and negative support, which was assessed with a scale of negative forms of the 5 basic forms of support. So, for example, how often has someone close to you said something that upset you? Or how often has someone left you out of an activity that you wanted to participate in? Opiates and cocaine were the drugs of preference among the population, in the samples, and the majority reported having had psychiatric diagnoses in addition to drug use disorders. So first we wanted to understand whether the population was able to mobilize support resources. We compared support networks of HIV positive and HIV negative persons who injected drugs, participants in the ALIVE study. And findings suggested that people living with HIV were able to mobilize support. We found that HIV positives had larger support networks comprising greater numbers of females and persons providing emotional or instrumental support. So indicators of caregiving. Across all studies, our findings revealed that the vast majority of people living with HIV had social support, a main caregiver, and had recently received informal care. At least 2/3 were able to enroll a caregiver in our studies, and we've achieved excellent retention rates. Almost half of the caregivers were themselves living with HIV, and the majority were women. While the caregiving literature finds or assumes that caregivers are better off than their care recipients, these understudied caregivers were comparably disadvantaged as their care recipients. Caregivers were primarily kin or main partners of their care recipient, and less than half lived together. And most had had prior experience of a person close to them having died of AIDS, of HIV. Caregivers reported high level of relationship quality, such as care recipients' reciprocity of support to them and relationship satisfaction. And over 1/3 reported HIV stigma related to their caregiving, feeling that they were treated differently or that other people were afraid to be around them, or etc., because of the help that they gave their care recipient. They also reported fear, likely misplaced, of being infected by HIV through their caregiving activities. So we wanted to see the accuracy of people's self-reports, patient self-reports of their adherence to ART, and also how accurate the caregivers were in their proxy reports of care recipients' adherence. And so we used dyadic analysis to examine the agreement or concordance between these reports and viral load. And we found that the findings indicated high agreement, suggesting high accuracy not only of self-reported adherence, but caregivers' proxy reports. And we found that agreement between caregivers' proxy reports and viral load were associated with caregivers reporting recipients' higher reciprocity of support to them and having had a loved one die of HIV. So these findings suggest potential relationship factors involved in activating HIV caregiving in these relationships. Next, we wanted to identify support resources that affected health outcomes directly. As in prior research, emotional support was cross-sectionally but not longitudinally predictive of depressive symptoms. Rather, among African Americans who used drugs, and this was regardless of HIV status, high depressive symptoms at 12 months were predicted by baseline reports of having a greater number of persons providing the material or financial support, and secondly, having fewer support network members with whom they had discord. We also found a high association between caregivers and recipients' depressive symptoms, and that better reciprocity of support and communication in the relationship were protective of depressive symptoms of people living with HIV. In structural equation modeling, we found that self-reported negative support and HIV stigma were independently associated with quality of life among people living with HIV. And this is even after adjusting for healthcare utilization and viral load. Next, we sought to answer the question of how support resources affected health indirectly through influences on health behaviors. We found that seeing the same healthcare provider, an indicator of access, was associated with a greater number of females in the support networks and a greater number of persons providing emotional and instrumental support and material support. And that outpatient service use was associated with a greater number of females in support networks and greater number of persons providing emotional support. And interestingly, regarding suboptimal use of EDs, and we define that by using the emergency department without being admitted, greater number of current drug-using persons in support networks was significant, but not individuals' own current drug use. Looking at access and outcomes of HIV treatment, we found that having a better or patient-centered patient-provider relationship was significant. In addition, viral control was associated with higher levels of emotional support and an interaction between emotional support and drug use status. Of those with high level of emotional support, not currently using drugs was linked to viral control. However, for those with low level of emotional support, current drug use status was not significant. So this finding suggests that current drug use may have affected health by interfering with the supportive function of participants' main relationships. We also examined predictors of achieving or maintaining viral control as compared to failed treatment over a 12-month period. And as in our prior studies, the results revealed that support resources were more strongly predictive than were individual level factors. And by the way, that's true of our cross-sectional analysis as well, cross-sectional studies. Specifically, having informal care, not living alone, and feeling comfortable taking ART around close ties were all significant predictors of achieving or maintaining viral control. And of note, commonly emphasized cognitive behavioral factors emphasized in the literature were not significant. Factors such as attitudes about ART and self-efficacy to adhere. We conducted separate analysis by sex to look at gender-specific correlates of adherence. Importantly, we found that for African American women, main partner factors were negatively associated with ART adherence. For women, having a main partner, and especially having an HIV-positive main partner, or a partner who is emotionally supportive, were risk factors for non-adherence. And that was even adjusting for relationship conflict. Now, among men, we found that ART adherence was associated with an interaction between having informal care and men's reciprocity of support. And we defined it, having informal care, as having someone to care for you if you were sick in bed and couldn't care for yourself. For African American men, having informal care was linked to ART adherence, but only among men who reported a higher level of reciprocity of support to their caregiver. This suggests the importance of mutuality of caring relationships for effective network function in health. Taken together, these findings reveal that traditional gender roles may play an under-acknowledged yet critical role in vulnerable African Americans' health disparities. And lastly, regarding indirect social effects on health, we identified significant second-order network factors. In particular, we examined characteristics of caregiver support networks that were associated with recipients' viral load. Results indicated that viral control was negatively associated with having a female caregiver and with caregivers' greater number of current drug users in their support network, as well as their caring for a greater number of youths involved in the criminal justice system. So this reveals evidence of the intersectionality or proliferation of multiple systems of stress and oppression in affecting African Americans' health disparities. 2/3 of participants reported they preferred making healthcare decisions with their family or friends, their family or partner. African Americans, compared to whites, have half the level of advanced care planning. And by that I mean preferences for end-of-life care, such as whether they'd want CPR if their heart stopped. We found that a greater proportion of HIV patients had spoken to their family or friends than it had spoken to their doctors about their end-of-life care preferences. And that's consistent with the literature, by the way. And only 1/3 wanted exclusively life-sustaining care at end of life. This suggests the importance of doctors, caregivers, and patients having these conversations together to ensure mutual understanding and that end-of-life care is aligned with their health values. Furthermore, in a sample of African American HIV patients at Hopkins, the majority reported that their doctor inadequately involved their family or partner in their health care. We then wanted to understand how stress-related comorbidities might affect support resources. We found that chronic pain, substance use, and depressive symptoms were independently associated with non-adherence to ART. In structural equation modeling, we found that these stress-related conditions of pain, chronic pain, depression, and substance use also affected adherence and viral control by independently affecting the quality of, or the patient-centeredness of the patient-provider relationship. Using factor analysis and structural equation modeling, we found that current substance use, meaning current illicit drug use or daily alcohol use, and chronic pain positively predicted negative social support 12 months later. We also found a significant interactive effect of substance use and chronic pain on negative support. Among those not currently using substances, there was a significant positive link between pain and negative support, but there was no association among those currently using substances. So this suggests the importance to social resources of integrating pain management into care models of drug dependence and HIV care. Now, HIV is neurotoxic regardless of viral control. With rising rates of neurocognitive disorders, we wanted to see whether support resources differed by cognitive function. And we found that a measure of executive function was linked to having cognitive impairment, was linked to having fewer network members overall, comprising less positively supportive and more negatively supportive network members among those with impaired executive function. And this slide just shows the network composition factors that differed by cognitive function. Our last research question was how caregiving affects caregivers' own health and well-being. Caregivers who reported higher stigma related to caring for their care recipients also reported higher depressive symptoms. We found a significant interactive effect between affiliative HIV stigma and disclosure of HIV caregiving to network members. Of caregivers who reported high affiliative stigma, disclosure of HIV caregiving to network members was predictive of their depressive symptoms. Caregivers who reported low stigma had lower depressive symptoms regardless of disclosure. This has implications for caregivers' depression as well as their own support for their caregiving. Finally, in latent class analysis, we categorize caregivers as being in a high or low social support group. 75% of caregivers were grouped in the low support group or class. And being in the low support class and limited physical function were associated with caregiving-related role overload. And that's defined as feeling overwhelmed and exhausted by caring for the caregiving activities they engaged in to care for the person. And this is an indicator, of course, of caregiving distress. And being in the low social support class was linked to being a caregiver who was female and HIV positive. In conclusion, our research contributes new methods and a framework for making visible a vulnerable community's health disparities and adaptive coping and resilience. The findings provide on-the-ground evidence that links results of epidemiologic studies, population-based studies, and physiologic mechanistic studies on health disparities, and in the field of HIV that are increasingly revealing the importance of stress processes in health outcomes. Most people living with HIV die from age-related, stress-related conditions, and not HIV specifically. So this is very important. The results support a novel biopsychosocial framework. In particular, they suggest interpersonal processes as potential fundamental mechanisms of neuropsychoimmunologic pathways of aging with HIV. The results reveal the need for new models of care to address vulnerable communities' health disparities. We need to identify and strengthen existing support resources of African American communities. Family-focused, strengths-based approaches are critical to addressing their unmet care needs and their stigma, both in living with stigmatizing conditions and affiliative stigma for caring for people with them. Integrative models of care are indicated and have implications for their health and for the effective function of their main caring relationships, both formal and informal. Dyad-focused interventions to improve social and emotional skills for support exchange may help reduce gender disparities in HIV health outcomes in the U.S. Of course, the results do not generalize to all vulnerable African Americans or people living with HIV who use drugs. And while we did not exclude the third of people living with HIV who did not enroll a caregiver, some of the findings don't generalize to them. Intensive strategies are needed for building their support resources. Low-threshold, comprehensive models of crisis care are indicated to help them engage in healthcare and treatment. One such model is the Baltimore Stabilization Center, which I had the honor of helping to mobilize stakeholder support for and launch last year. Finally, I want to express my deepest gratitude to all the people who inspired and supported me and made this work possible. I thank David and Peg and Mary Mitchell, my main collaborator, and of course my partner in all things, Carl, and all the people at the Lighthouse, who are too numerous to mention and have been like family to us over the years. And finally, I want to thank study participants for sharing their love. Thank you.
Thank you, Amy, for a great presentation, and what an enormous and deep body of work this is. It's just incredible. It also reminds me what a resource these large cohort studies like ALIVE is for the Bloomberg community to do some incredible research. Let me just take the prerogative and ask the first question. You talked a little bit about implications for interventions, but what would you like to see the next step in your research? What would be the ideal next study you would like to take on?
I would love to look at, do a longitudinal study of stress processes in the population using ambulatory devices as well as biomarker research to study systems level processes of aging, stress and aging in the population. And in fact, have a proposal under review right now, so.
It may become a reality.
And of course, the other thing is, I think we really need to get dyad-focused interventions for pain and stress management into addiction treatment and primary care facilities everywhere.
Yeah.
Very, very important.
Yeah.
And that's also under review, so.
Yeah, okay. Other questions? Comments? Yes.
Thank you. Holding confounders constant, what is a typical change in longevity that you might see between people who have a good or a bad social support network?
First of all, I'm trying to move away from good and bad binaries, as my kids tell me. And a more complex, challenging, I could not even begin to answer that. I think it's a great question. I don't think the science is there to quantify actually that, and that's why I think such a longitudinal study would really help to answer that. Just how many years are shaved off from both the social mechanisms as well as the other physiologic mechanisms. Good question.
Hi, thank you for your presentation. I'm wondering if you could talk a little bit about whether you've engaged with providers or even with the city and the health department about making some of these changes that you're talking about how providers engage with the patient, but also their caregiver network, the dyads, the sort of the core people that they engage with as a way of improving their adherence and care.
You know, what's amazing to me is the number of times I've been asked about years ago, decades ago, and this is part of what drove this research, is I was asked, we've got money, the state AIDS administration asking, we've got money set aside for families for HIV. I don't even know how to begin to, and coming to me asking, what do we even use that for? And I couldn't answer it at that time. And that's really tragic. And I've had people in PopFam say, families in the name of our department, and we don't do family work, It's not passé. It's survival of the nurtured. And I think this is where we really need to be with our research, is really trying to understand the relationships that people depend on every day. So I think so it's hard to answer that. I've worked with a number of city and state agencies, and I can't say that I've done nearly enough to try to help guide some of the resource allocation for families. But absolutely, I think this is something that moving forward, where I want to take this research.
Amy, thanks for your talk. You made a little joke at the beginning about apps maybe solving our problems. Do you see any place for sort of new media or social media in terms of the connectivity and the dimensions of support, like emotional support? Are you optimistic about any of the innovations that they might represent, or is it going to pass this population by?
That's an interesting question. I think absolutely there's so much connection that can be fostered remotely using social media and technology, and it's vital to helping people maintain connections. I'm not an expert in that area. Megan, next to you, could probably answer some of that. It does seem that there's challenges though as well that people are exposed to using social media, that it's so much easier to get negativity from use of social media that, as research clearly indicates, is far more nefarious to health than the positive. So really, it's important, but I think social media alone is not going to be fully the answer. But certainly, a lot of caregivers may be isolated toward the end of their caregiving for a person, and certainly in those cases, technology is so critical to giving them the information and resources, support they need. Hi, Peg.
So thanks for such a clear and well-organized presentation. It was really nice to see the progress and the questions answered. And I have a question, may not be a fair one, but what the heck, I'd like to know the answer to it. So can you reflect at all on how important having a social network methodology has been for your work and for your findings? I can take that answer later if it's.
Yeah, it's interesting because I go back to thinking about our colleague Leonard Perlin, who Peg and David and I did a study with that really early on in my career that really got me thinking about this. And he was so excited because he said, wow, you know, he did a lot of the conceptual work. However, he was so excited about me using a network methodologic approach because he said, you've got it. You know, this is what we need. And this is what he didn't have access to, or of course, the software to do this type of analysis. So I think I don't know how much that answers your question, but certainly from, you know, the opinion of a pioneering sociologist, medical sociologist, I think it's been enormous. And just as importantly, the software and innovations in data analysis that makes it possible.
I think there was a question. Janice.
Hi, Amy.
Hi, Janice.
Thanks so much for a great presentation. You've heard that from everyone else. As I listened and looked at your slides, the thought occurred to me that do you foresee a point in time in your work, or even up to this point, where you have observed the resiliency of some of the participants that you have worked with? I think we have gotten kind of a clear picture of what are their struggles and where support, when it's absent or depending on the type, works or doesn't work well, and around the caregiver stress. But I wondered if any of this has led you to an understanding or even a desire to try to build on and capture resilience, or building capacity among people to be able to kind of rise above their circumstances, or at least to be able to cope with them in a way that isn't so tough or so challenging on a daily basis, and whether we can get to the place where we're ever promoting that sort of strength-based approach to the work.
I have to say that that's an excellent question, and that there's so little research on resilience, period. And just like with social support, we're at a very early stage of really trying to figure out how to even assess it. I see it every time I walk into the lighthouse and hear the stories that just leave me in tears. The obstacles that people are dealing with every single day, the persecution, is just phenomenal. And to be able to endure and to have enough love left over for others is a testament to something, and whatever we want to call it. I'm hoping that we'll have a delineation of types of resilience eventually. Right now, a lot of it comes under the heading of faith, of spirit. And it's hard, and it's hard to know, how do you conceptualize that? How do you measure it? There's a quality of faith that I hear more than anything in the participants' own language And so I'm hoping that we can, and you can help, move toward a better understanding of resilience in this community, what it looks like, what it feels like, new language to describe it. Thank you.
Oh, yes, in the back. Oh, yep. Playing my Vanna White.
Thanks for the wonderful talk. These are my favorite talks because it's great to hear how people's research evolved over the years. And as someone who studies HIV, I wonder if you could just talk about like where you started and, you know, where the field is now. I have lots of thoughts, but I would, you know, I find it interesting that we're now thinking about aging populations in HIV, something sometimes some of us never thought would be a research topic. Women in HIV, like you talked about intersectionality. So I would just love to hear any thoughts about the evolution of the field that you've worked in for so long.
Small question.
Yeah, I think David Celentano would be more qualified to tell us all where the field has gone over the decades. Myself, I feel like I started in a little niche area that no one was looking at, and I feel like the entire field passed me by decades ago while I kept tinkering at the margins with the marginal. And so there's a lot that, and I think a lot of it went along the direction of big pharma, and this type of work, I think, really, first of all, so much of the work on psychosocial support services that was talked about at the beginning of the epidemic just totally erased after the advent of the highly active treatments. So it really has been, from my perspective, a total embrace of a pharmacologic magic bullet approach to dealing with the epidemic and PrEP now for people who are HIV negative. It may be very important, and yet, there's a lot left out of that picture.
I think we have time for, a couple more questions. Well, we have one up here, and then we can get back to you guys. Yep.
Thank you very much for your presentation.
Sure.
I was curious, so as a clinician, oftentimes I try to bring in the dyad, bring in the caregiver to help support the person who's managing usually chronic illnesses. And it strikes very true to me what you presented, that oftentimes that person is also some form of being marginalized or has their own health issues. And I'm wondering from your perspective, how do you envision that dyadic approach? Number one, as what do you imagine would be kind of the acceptable way of providing care that way? And then also, if there's a role for, I guess, reorganizing the way that we provide care.
Yeah, thank you. Excellent question. I think that one of the things to experiment with, and it's not real clear how exactly in the context of a totally busy clinical practice one can possibly add, the random factor of family members. Right now in our current healthcare system, I feel for you. It's very hard to even have time to answer the patient's questions, let alone family. And I think, one thing to remember is that we're talking about social norms. We're not talking about individual rational, logical behavior in so much of health behaviors. It's a collective sharing of norms, and it's the norms that need to be altered. And for disadvantaged people, if they don't have a way to get to the pharmacy, if they don't have money for transportation, these things don't matter. And so I think perhaps as a first step, it's maybe for certain types of patients or certain types of visits, it may be prudent to try to test out, can we integrate partners or family members ideally? Well, both of them are very, very important. Often partners are preferred as being the source of care, but they're not necessarily the ones actually caring, being the main caregiver, which is why they're so important. And African American women will tell you, they want, I know my brother wants his children to help him, but I know I'm going to be the one, And it's a very matriarchal kind of family structure from what I've seen. So I wish I could answer that. One of the things, the proposal I have under review right now is introducing a dyad session with a family member in addiction treatment at the Addiction Treatment Center at Bayview, which Mike Kidorf has been doing for a long time. However, that doesn't start until after they've graduated, 6 months in the program. And they define family as a family member who is not currently using drugs. And so that's a way to actually have double the impact of your treatment program by intervening with them together. So we're not there yet. This is all, very new, and it seems very challenging given the healthcare delivery system as it currently exists. And it's important.
We have time for 2 more questions. Deborah and then Roger.
Thank you. Thanks, Amy. I very much enjoyed your talk. And my friend Rajiv gave me the microphone. But because I was excited to respond
it's the end of the day.
To our clinician member of the audience. Because my sense of where a clinician falls within the social support network is such that I think particularly for people who have less social network around them, clinicians are a very strong source of social support. And it doesn't take much to express it and convey the power that clinicians have to encourage, to respect, to confirm and affirm the potential for a patient to be engaged and powerful and empowered. I think, though, I heard lots of discussion around talking about the dyad, and as I understood, your reference to dyad was between the patient and the caregiver. So when I think about clinical interactions and the studies that I do within the medical context, it's triadic, because very often those patients, the sicker, the older, the more vulnerable the patient is, the much more likely they are to be accompanied by, I call them a visit companion. They may or may not fit a very, narrow notion and definition of caregiver, but they're care partners. And it may be family members, it may be adult children, it may be spouses, it may be other relatives, but unpaid care. And the reason this is so important is because there are really influential positive roles that patient companions play in that interaction dynamic that can transform a medical visit to what we think of, what I think of, what I measure as patient-centered care, which conveys this sense of both emotional and instrumental support. Patients leave thinking about whether they're being respected, whether they trust a provider, whether they now can trust their family member to understand what it is they want and how they can achieve it. And while I think your response that, of course, clinicians are put upon in terms of time restrictions. And, maybe too idealistic, but I do observational studies that say investing in relationships saves time. So that if you ignore the need for people to establish contact with one another in a deep way, and it doesn't take that much time, it has much in return in terms of confidence for adherence, confidence to get through challenges. And, and I wonder, in regard to Janice's statement, this notion of where does resilience come from? And we've had many conversations about faith, but it also comes from conveyed sense of respect, a conveyed sense of recognition of personhood. And that is in itself inspiring and empowering. So anyway, that my take on this is that clinicians are really important, substantive, and real sources of social support. And they manifest perhaps not always explicitly, but implicitly when the patient leaves that room.
Yeah.
They know whether they felt they had a connection or not. And I would love to see that, feature more broadly in this literature.
Yeah.
And so relinquish the microphone.
Thank you.
So this is very appropriate because the question I whispered in Deborah's ear right before she asked her question was, have you guys published together? And the answer was no. And I sat here thinking, actually the work overlaps a tremendous amount. It's just that the context may be different of HIV and so on. So that was my comment. My question was sort of more at the margin. I think one of the things that really stood out for me in one of your slides was the idea that the care recipient is dealing with a lot of stress.
Yeah.
There's a lot of literature obviously on the caregiver stress, but I had not really previously thought about care recipient as that being a very stressful experience. And so I was wondering if you could unpack that a little bit. Is that about guilt? And what is that about?
Oh, tremendous.
And what kind of outcomes do that have?
So one of the contexts of these relationships to appreciate is that with the addiction career, with the history of addiction, there's a lot of under the bridge. And there's a lot of sense of having failed the people they love most, and having destroyed confidence, trust, and most of these are family members that people feel anguished to have let them down again and again and again with their addiction. So there's a reluctance and a norm of not asking for care and not wanting to accept it. And that's actually one of the questions we ask. And it was a barrier to people saying that they would, one of the saying that you don't want to ask people for help because you don't want to owe favors was a predictor of preferring professional care at end of life over informal care. And given that formal care is not even really an option for most people, it tells you something of how reluctant people are to accept care that's even offered.
Well, thank you, Amy, for an incredibly thoughtful and thought. It makes us think about a lot of things. And thank you all for a great discussion. I think these questions were terrific. So much more to be done in this area, and we're thrilled that you've devoted your career to answering some of these questions. So thank you.
Thank
So
you.
please join us in the gallery for some refreshments, and we'll see you there. Thank you.